So I think one of the biggest conundrums, this goes to the point of talking about, how do you pick this balance of quality and quantity for your patients? And PSMA has only made that more complicated, in my opinion.
Yeah.
So I have some kind of general scenarios that I'm like, be curious as to how you guys manage it, knowing that there's no 100%. You talk to the patient, you get the history, you get a feel for what they want to do, what their pain points are or not. But with PSMA PET, having this increased detection rate, of course. Let's start, Dr. Agarwal. If you got a guy, initial staging, conventional imaging would be negative. Let's say it's unfavorable, intermediate, high risk, and it's N1 on a PSMA PET. Like, what is your over 50% move in terms of managing that patient? Because all the 10-year go studies are telling us that's local, that's local, that's local.
Yeah.
If it was N1 on conventional and CCN say, hey, let's do some systemic and some radiation, how are you incorporating the unknown with trying to do what's best for the patient?
Yeah, that's a tough question. I think that each patient's individual, but a lot of times the first thing I'll do is review that image with the radiologist, because many times that N1, there's no actual radiological correlate. It's just positive.
Yep.
But when you look at the conventional CT that's associated with the PET, there's no actual lymph node that's lighting up.
Mm-hmm.
The other thing is, in some PSMA PETs, whether it's F18 or gallium or, what am I missing there? Polarify. There's little differences and nuances of where the uptake occurs. One is more sensitive for bone, one is less, one has more false positives. So I think understanding the nuances of the PET, but just to go back to the question, not trying to dodge it too much.
No, not at all.
But if you have
opening my other question.
But if you have an N positive patient and there actually is a positive node there in the pelvis, if they're a young patient, you have a little bit of leeway now, right? Whereas before, if it was unconventional, you say, man, you're not going to be cured. But maybe there's a leeway to say, hey, we don't know if that's actually a positive node. There's a false positive rate, right? So we still proceed with maybe a prostatectomy, include the node in the field, and then we find for diagnostic purposes. You could also try to biopsy it with IR to say, hey, is this an accessible node to biopsy to prove is this metastatic disease?
Sure.
Because then there are implications, right? Prostatectomy has serious side effects for the patient's quality of life. So I think it's nuanced. For me, I always try to figure out, is that node actually real or not? And that'll exhaust that, whether that's with the radiologist, with a biopsy. And if it's still indeterminate, I'm going to give the benefit of the doubt probably to the patient if they're young enough and want to be aggressive to consider a surgical removal of that lymph node with potentially their primary cancer. So.
And are there tracers in particular? I mean, you mentioned the most popular, like that you would prefer to see.
We're lucky we have access to all of them. I think a gallium to me is like the gold standard, gallium 68.
Mm-hmm.
We have Polarify. It's so easy to order because it's like more accessible.
Right.
But luckily we have a gallium scanner at our Mercy South location, so we can do that if you're questioning something. So it's like, I do think they're all pretty good though. I mean, there's not too much huge of a difference, except for when there's a case of like subtlety where you have to figure something out. But even a conventional PET, they say, is
it's not bad.
Terrible for a really aggressive prostate.
Yeah, and so they talk about 10 to 30% depending on castration-resistant negativity on your PSMA PETs. I'll raise my hand. I'm not good about doing this part, but are you guys doing FDG PETs, which is saying, hey, you know what? Yeah. Let's clarify. We really think there's something there. Are you guys utilizing that at all in this space?
I'm mostly doing the Polarify. I like to do that if if they seem symptomatic, I might CT and bone scan. But I mean, I think in general, I try to get a Polarify if I can get it through the insurance. Yeah. And the way things are changing. I mean, it's the different imaging modalities. Like for breast now, we have PET Siriana, which is I've done that on one person recently. We just got that at our center. And I saw 2 other patients today, and I was like, hey, we can do this PET Siriana. You can't do that one if they're on a SERM like tamoxifen or fulvestrant, but otherwise you can. So sometimes I think it's important to know which drugs they are on so that you don't wind up ordering the scan and then you obfuscate it. You can't interpret it. It's like, oh, they shouldn't have been on this. So that was an interesting learning point, I think. But it definitely, is, the sensitivity of these newer PET scans has been remarkable, because we've seen it at conference. A lot more patients showing up with some oligometastatic metastatic disease that we didn't suspect, and that changes your management.
Well, and so that's where I kind of want to go. If you have I'd really like to hear you guys' thoughts on this, because I think this is the harder one. You have, so not N1, you have metastatic site, negative conventional imaging, and let's say it's an oligomet. We talk about less than 4 on conventional imaging. There's a number of criteria based on some different trials. Dr. Strobe, let's say you got a single bone met, de novo disease. And conventional looks reassuring. What would you think is?
So unfortunately, a bone biopsy is very low yield,
Yeah.
and so you don't really have a great biopsy option there for you. So your choices are to say, I don't believe it, and proceed with what you would have done anyway, which then you're, by all the data that we have, your standard of care, right?
Yes.
Because nothing that we have was based on finding oligometastatic disease on PET scan. Or you could say, well, that might be real, so I'll radiate it, because there are data points for radiating oligometastatic disease, but it's not in the guidelines, and so you're kind of extrapolating beyond where guidelines are right now. I guess personally, I've gone not aggressively on prostatectomy in those cases, because I've worried that I'd be too aggressive for that level of disease, and I've gone more towards the systemic therapy. That goes back to your point, though. It'd be nice if we had some other really good biomarkers that we could use to help us with that, to go, wait, this is suspicious, and I've got this other thing that tells me that it's really suspicious. I think if you were following the guidelines and you had a unfavorable intermediate risk, you got a PET and you got that, and your PSA was 6, and the only thing that was unfavorable was your Gleason 7, and then you might be like, I don't know.
I'm not sure I buy it.
I'm not sure I buy that. Like, I never even in the old guidelines would have gotten that scan at all. So that's, I mean, that's where it becomes really subtle. I mean, I recently had a guy whose only disease outside the pelvis was a ganglion that was lighting up on a PET.
And so that's
and it was lighting up. There's no CT correlate for it. So I'm like, do I not treat him? Do I call him like broadly metastatic? And
so I think that's a good point of those false positives, especially ganglion, so parasympathetic ganglion or sympathetic ganglion, like absolute sympathetic chain is risk for false positivity, and people that go and don't know that are like this retroperitoneal lymphadenopathy. And you have to be very careful with those PSMA false positives.
He actually had GI symptoms though. And it's like, is that related? And so like when I started his ADT, I'm like, are your GI symptoms better? And he's like, yeah. I'm like, oh, so was that real? I don't know.
There's a report of macrophage having PSMA expressivity. Have you guys noticed this in like inflammatory stuff, like false positives at all in those PSMAs?
Lately it seems like I've gotten a couple of lung nodules, and that's where I end up getting an FDG PET.
Okay.
Back to that. But I had a lady the other day, a guy the other day whose thyroid lit up, and we did an ultrasound, and he had a thyroid tumor. I mean, that's not listed in the cross-reactivity, but...
Right. Yeah, I think knowing those, when to chase it and when to not is a good skill set to hone. So I think we've covered a good bit on some of the role of radiation in these spaces.
Oh, one thing I was going to say is the CLL. Well, you got to be careful on that too, because we'll see people who have this smoldering CLL may have, they're of that age where you could get both prostate cancer and that. And so that's where, they may say node positive. That's where maybe a biopsy or peripheral smear or somewhere or other.
They'll have adenopathy and it's CLL.
Right.
Exactly. And they'll light up on those PETs or PSMAs even.
So, Dr. Freeman, I'm curious for your input on this one, because we've talked about what the heck do we do with radiation surgery for these, PSMA, differences. When you're seeing, classically, charted, stampede, high volume disease on a PSMA PET, but not necessarily meeting conventional, how are you managing those patients in terms of chemotherapy?
I'd look at, individualize it, kind of see, okay, how old are they, the PSA velocity, look at all those features, and we've reviewed a lot of those patients at conference, and typically, the med oncs will speak up and say, do they have 4 or more lesions, how many, and but I think it's a great point too, getting back to, the Taxotere data, docetaxel, is almost, when you look at those trials that show maybe it's a 16-month improvement in their overall survival, which was very surprising. When they designed those trials, they said, oh, we got this signal. I don't think they were expecting that. But that's kind of in the pre-darolutamide, pre-enzalutamide era. I mean, it's before
2004.
Yeah, it's before we had such effective systemic therapy, so it kind of makes you wonder, are they going to be able to compare in this modern era?
Yeah.
So that makes it difficult. But, and another point I would get at is, we've had mutual patients. Some person's getting docetaxel. We'll never forget the guy. His brother was a famous, AML researcher, and this guy, Dr. Agarwal said, "You're done. You've had like 4 cycles. Dr. Finney is not going to give you 5 and 6." Appropriately.
It tears him up a little bit.
Because this poor guy was just,
strong.
you have to look at the patient, like docetaxel is, asthenia, especially 75 milligram per meter squared. I mean, it's a tough. And if you're trying to translate to give them that, so it's kind of like the paradigm of head neck chemoradiation. You put them through this unbelievably horrific thing to give them a cure for decades.
Yeah.
And docetaxel, you select the right patient and make sure they know kind of what they're getting into. And it does have a big magnitude of benefit, but it's still something to think about.